My name is Carol Bagnall, and I am a sonographer working in women's health. This presentation gives guidance on how to optimise the nuchal translucency examination. Quality improvements to antenatal screening were introduced in New Zealand in 2010 when maternal serum screen was combined with the nuchal translucency, NT, and crown rump length, CRL measurements. Previously, maternal age and then NT were used to screen for Down syndrome and other conditions. A high-quality 11 to 13-week scan and precise NT and CRL measurements are essential in providing women with an optimum risk result for antenatal screening. There is a tendency to undermeasure the nuchal translucency. It is important the NT and CRL are measured correctly due to the amplification of errors that can occur when they are not measured precisely. This presentation provides guidance and a refresher on best practice and includes tips for optimizing both the image and the measurements. Note that different equipment will require further tailoring of the examination. As part of the 12-week scan, we should document the early fetal anatomy and placental location. This presentation is only about optimizing the NT and CRL measurements. The results of the maternal serum test, known as the MSS1, rely on an accurate CRL measurement. The CRL is used to standardize the biochemistry. If the CRL is undermeasured, it may increase the chance of a false negative screen rate, and if it is overmeasured, it is more likely to increase the false positive screen rate. To obtain a precise CRL, you need to take a sagittal view of the fetus in a neutral position horizontal on the screen. Calipers are to be placed on the crown, which is the skin above the parietal bone, and the rump, which is inferior to the tip of the sacrum. For antenatal first trimester screening, or MSS1, the CRL should be between 45 and 84 millimeters. You need to use appropriate depth and magnification. Ideally, the scan is done around 12 to 13 weeks when the CRL is 56 millimeters or greater. The measured CRL axis should be at 90 degrees to the ultrasound beam. Measuring at angles greater than 30 degrees will likely lead to measurement error. This slide demonstrates the fetus lying in a horizontal position in a sagittal view with the calipers placed correctly at the crown and the rump of the fetus. This slide shows a fetus lying in the correct position with the calipers placed at 30 degrees, which is acceptable. However, it would be more ideal to have the calipers placed on the horizontal with respect to the ultrasound beam. This slide shows the fetus in correct sagittal position but where magnification has not been used, making it harder to correctly place the calipers. The following 3 slides demonstrate how much variation in measurement can occur depending on fetal position, thus stressing the importance of correct fetal position when measuring the CRL. This slide shows the fetus in the correct position where appropriate magnification has been used, so a reliable CRL can be obtained. This is the same fetus but with a poorly obtained CRL demonstrating undermeasurement of the CRL at 49.8 millimeters, which is a difference of 7.7 millimeters from the previous slide. This slide shows the same fetus but where the angle of the fetus with respect to the ultrasound beam is greater than 30 degrees. This fetus is also not in a sagittal position. This demonstrates an undermeasurement of the CRL at 53.2 millimeters, which is a difference of 4.3 millimeters from the first slide. To obtain a good quality NT measurement, the fetus needs to be in a midline sagittal position, using the intracranial landmarks of the diencephalon, midbrain and fourth ventricle to guide you. The maxilla should not be visible. You should use the highest frequency transducer available. This may be a linear probe, a curvilinear probe, or a transvaginal probe. You need to adjust the depth and the magnification so that you demonstrate only the head and upper thorax in the field of view. Adjust the gain settings, adjust the dynamic range and place the focus in the correct location. You need to measure on the line to on the line that defines the NT and measure the widest part of the NT. This slide shows the NT measurement where appropriate magnification has been used. The fetus lies in a midline sagittal position with the appropriate intracranial landmarks seen. You can see there is no maxilla present, the intracranial translucency at the back of the fourth ventricle is present, and the amnion is visible at the back of the fetus. To help guide you that the fetus is in the correct position, you should note that the fetal palate should be between 30 and 60 degrees relative to the horizontal as shown in this image. The fetal head should not be too flexed onto the chin. The nasal tip should be level or above the anterior abdominal wall relative to the horizontal, and there should be a pocket of fluid at least equivalent to the size of the palate visible between the fetal chin and chest. Shown here is how the same fetus can be imaged and differing NT measurements can be obtained. The same frequency probe was used, but the fetus is in a slightly different position, and the only other adjustment was the gain. The high-quality image is on the left, demonstrating an NT of 1.8 mm. By adjusting the gain and position, you can see that the NT is 1.6 mm, which has resulted in an undermeasurement of 0.2 mm. Here we show the difference in NT obtained using different magnification settings. This is the same image taken where in the left-hand side of the screen the appropriate magnification is used and the NT measured is 1.8 mm. In the right-hand image, magnification was not employed and the NT was 1.5 mm, resulting in an undermeasurement of 0.3 mm. Using different frequency settings can change the NT measurement. On the left-hand side, a linear high-frequency probe was used and the NT was measured at 1.8 mm. In the right-hand image, a 1.5 MHz curved array probe was used and the NT was measured at 1.4 mm, an undermeasurement of 0.4 mm. In this slide, the top left image was taken using a high-frequency 4 to 8 MHz curved array probe and the NT is measured at 1.8 mm. In the right-sided image, using the C15 MHz lower frequency probe with poor magnification, the NT is measured at 1.2 mm, an undermeasurement of 0.6 mm. Note how the intracranial landmarks are not well defined and caliper placement is poor. This next slide demonstrates how a transvaginal scan can help when the fetus is in a difficult position. The slide on the right shows that the fetus was in a difficult position and the NT was unable to be obtained. The slide on the left is the same fetus using a TV scan where the NT was obtained at 1.4 mm. Operator and skill can affect the NT measurement obtained. Junior staff, practitioners who perform NT less frequently, and those needing to improve the quality of the images should be provided with support and mentoring by practitioners with the skill to obtain high-quality images. The image on the left demonstrates the NT obtained by someone who is less experienced or requiring support in NT scanning. The measurement is taken here at 1 mm. The image on the right is a high-quality image of the same fetus obtained by a more skilled practitioner. The measurement obtained is 1.8 mm, a 0.8 mm difference. This is the same fetus demonstrating the image on the left where the operator had not taken a satisfactory CRL measurement and the CRL is over-measured. The image on the right shows the appropriate CRL is obtained and is measured at 62 mm. There can be a degree of luck involved in trying to manoeuvre a fetus into the optimal position for obtaining an accurate NT. In the top left image, a fetus is shown in a difficult position. The same fetus is shown below this image and to the right where techniques have been used to manoeuvre the fetus. Techniques employed are at the sonographer's discretion and depend on individual circumstances on the day of examination and can include getting the woman to fill or empty her bladder, rolling the woman from side to side, delaying scanning by 30 minutes to an hour. So in conclusion, it is important to remember it is the little things that count in obtaining a high-quality nuchal translucency and crown rump length measurement. To get the most reliable risk result for women, we need to optimize the ultrasound image every time, use high-frequency transducers when possible, adjust settings, 1 gain, 2 magnification, 3 frequency, and 4 opt for TV scan when appropriate. We may need to delay scanning, and remember, if you cannot get a good NT image, then second trimester screening is available.